In this video, we are going to cover cerebrovascular accident or stroke. Stroke is a functional abnormality of the central nervous system that occurs when the sudden interruption of circulation in one or more of the blood vessels supplying to the brain. During a stroke, brain tissue fails to receive adequate oxygenation, resulting in serious tissue damage or necrosis. In a stroke, functions such as movement, sensation, thinking, talking, or emotions that were controlled by the affected area of the brain are lost or impaired. The severity of the loss of function varies based on location and extent of the brain damage. Stroke can be divided into three: ischemic, hemorrhagic, and TIA. In ischemic stroke, blood flow to a part of the brain is inadequate due to a blood clot within a blood vessel or stenosis of an artery that feeds the brain tissue. This limits the blood that can reach the brain cells. This type of stroke can happen due to embolism or thrombosis. Embolism, where a clot has left a part of the body, examples, the heart. This can happen due to a heart valve problem or atrial fibrillation. The clot develops in the heart and travels to the brain, which stops blood flow to the brain. In thrombosis, where a clot forms within the artery wall within the neck or brain. This is seen in patients with hyperlipidemia or atherosclerosis. Next is hemorrhagic. Hemorrhagic occurs when there is bleeding in the brain due to a break in the blood vessel. Therefore, no blood will perfuse to the brain cells. In addition, this can lead to excessive swelling from the leakage of blood in the brain, bleeding into the brain that results in the death of brain cells. Causes of this type of stroke includes rupture of a brain aneurysm, uncontrolled hypertension, or aging blood vessels. Next is TIA. Transient Ischemic attack, also called a mini stroke. This is where signs and symptoms of a stroke occurs but last only for a few minutes to hours and resolves. It is a warning signs of an impending stroke may occur. If this occurs, the patient needs to seek treatment. Thrombosis, embolus, and hemorrhage act in different ways. Thrombosis of the cerebral arteries that supply the brain or the intracranial vessels, occluding blood flow. Thrombosis causes blockage and edema in the affected vessel and ischemia in the tissue supplied by the vessel. Embolism from a thrombus that formed outside the brain, for example in the heart, aorta, or common carotid artery. This embolus cuts off circulation in the cerebral vasculature by lodging in a narrow portion of the artery, causing ischemia and edema. If the embolus is septic and if the infection extends beyond the blood vessel wall, an aneurysm may form, which increases the risk of a sudden rupture and cerebral hemorrhage. Hemorrhage occurs in an intracranial artery or vein, possibly due to hypertension, ruptured aneurysm, arteriovenous malformation, trauma, hemorrhagic disorder, or septic embolism. In hemorrhage, an artery in the brain leaks, rapidly reducing the blood supply to the tissue served by the artery. Blood accumulates deep within the brain, causing even greater damage by further compromising neural tissue. The blood supply to the brain comes from the carotid and vertebral arteries, which then branch into other arteries that feed the brain. In any of these areas of the artery become blocked or burst, it decreases the blood supply to the brain cells. Brain cells are very sensitive, and within 5 minutes, these cells start to become damaged, and the damage can become irreversible. Next is risk factors. In risk factors, we have non-modifiable, modifiable risk factors. In non-modifiable risk factors are advanced age, older than 55 years old. Strokes are more common in male and African Americans. Modifiable risk factors are hypertension, atrial fibrillation, hyperlipidemia, obesity, smoking, diabetes, periodontal diseases, asymptomatic carotid stenosis, and valvular heart diseases, for example, endocarditis, prosthetic heart valves. These risk factors can be modified by medicine, exercise, and diet. Now we'll see lobes of the brain and their function. Strokes tend to affect only one side of the body. The right side of the brain is the creative side, while the left side is the logical side. Right side functions are attention span, showing emotions, ability to solve everyday problems by making decisions, plans, reasoning, that is understanding jogs, reading in between the lines, making judgment calls, memory, music or art, awareness. Right side of the body controls the left side of the body. If a patient has right side brain damage, left side weakness will happen. Hemiplegia, impairment in creativity, arts and music, confused on date, time, place. The patient cannot recognize faces or the person's name, loss of depth perception. The patient may have trouble staying on topic when talking. Patient can't see things on left side. Patient will have unilateral neglect, ignores left side of the body, trouble with maintaining proper grooming. Patient will be emotional, not going to think things through, very impulsive, poor ability to make decisions and assessing spatial qualities, shapes, denial about limitations, not able to read nonverbal language or understand the hidden meaning of things. Patient will have very short attention span. Left side functions are speaking, writing, reading, math skills, analyzing information, planning. Left side controls the right side of the body. If a patient has left side brain damage, right side hemiplegia will happen. Patient will have aphasia, trouble formulating words and comprehending them, aware of their limits, experiences depression, anger, frustration. The patient will have trouble understanding written text. Patient can't write. Patient will have agraphia, that is not able to write. Patient will have impaired math skill. Patient will have memory intact. Patient will be having issues with seeing on the right side of the body. When there is brain cell death in a certain area, it will cause specific signs and symptoms. The amount of brain damage depends on how long it took for blood to return to the affected brain cells. Next, we will see signs and symptoms of a stroke. We have to note the exact time the signs and symptoms appear. It is very important for stroke treatment. The general signs and symptoms include numbness or weakness of face, arm or leg, especially on one side of the body, confusion or change in mental status, trouble speaking or understanding speech, visual disturbances, loss of balance, dizziness, difficulty walking or sudden severe headache. The patient will have motor loss such as hemiplegia, hemiparesis, flaccid paralysis, and loss of or decrease in the deep tendon reflexes. That is the initial clinical feature, followed by reappearance of deep reflexes and abnormally increased muscle tone, that is spasticity. It happens after 48 hours. Patient will have communication loss. Patient will have dysarthria, that is difficulty speaking, dysphagia, impaired speech or aphasia, loss of speech. Patient may experience apraxia, inability to perform a previously learned action. Patient will have perceptual disturbances and sensory loss. Patient may experience visual perceptual dysfunction, that is homonymous hemianopia, that is loss of half of the visual field, disturbances in visual spatial relations, perceiving the relation of two or more objects in spatial area, frequently seen in patients with the right hemispheric damage. Sensory losses such as slight impairment of touch or more severe with loss of proprioception, difficulty in interrupting visual, tactile and auditory stimuli. Patient may experience impaired cognitive and psychological effects. Frontal lobe damage may impair learning capacity, memory, or other higher cortical and intellectual functions may be impaired. Such dysfunction may be reflected in a limited attention span, difficulties in comprehension, forgetfulness, lack of motivation. Some patients may experience depression, other psychological problems such as emotional lability, hostility, frustration, resentment, and lack of cooperation. National Stroke Association recommends to use the mnemonics FAST, F-A-S-T, to help assess for signs and symptoms quickly. Face. In face, drooping or uneven smile can be seen. Numbness, weakness, drift is present. Speech. Patient can't repeat a phrase. Patient will be having slurred of speech. Time to call, a rapid response, and not the time. It is very important for us to note the time of the onset of signs and symptoms. Next, we will see diagnostic evaluation. Patient's history and a complete physical and neurologic examination to be done. 12-lead ECG and a carotid ultrasound to be done. MRI or a CT scan shows evidence of thrombotic or hemorrhagic stroke, tumor, or hydrocephalus. Brain scan reveals ischemia but may not be positive for up to 2 weeks after the stroke. In hemorrhagic stroke, lumbar puncture may reveal blood in the CSF. Carotid ultrasound may detect a blockage, stenosis, or reduced blood flow. Ophthalmoscopy may detect signs of hypertension and atherosclerosis in retinal arteries. Angiography can help pinpoint the site of occlusion or rupture. EEG may help localize the area of damage. Other laboratory studies such as urine analysis, coagulation studies, CBC, serum osmolality, anti-electrolyte glucose, lipid profile, anti-nuclear antibody, creatinine, and blood urea nitrogen levels help establish baseline organ function. Now we will see the medication or treatment for acute ischemic stroke. Support of vital signs. We have to maintain airway, breathing, oxygenation, and circulation. Maintain pulse oximeter greater than 92%. Utilize oxygen therapy if needed. Arrhythmias are common. Telemetry may be indicated to monitor. Atrial fibrillation is the most common arrhythmia in stroke population. Atrial fibrillation is an abnormal heart rhythm, that is arrhythmia characterized by a rapid and irregular beating of the atrial chambers of the heart. IV fluids, so normal saline to be given to the patient at maintenance until able to tolerate oral diet. Colloids may be used for reperfusion and hemodilution. We have to maintain BP within prescribed parameters. We have to limit the fluctuations of BP. Management of systemic hypertension with labetalol, nicardipine, or alternative IV antihypertensive agents to keep systolic BP less than 200 mmHg. Goal is to promote adequate cerebral perfusion to prevent further ischemia. Our lowering BP greater than 25% within the first 24 hours. Hemorrhagic conversion or transformation can occur and is associated with a degree of necrotic tissue and vascular injury. Hyperglycemia and BP fluctuations or rapid increases in BP increase the risk of hemorrhagic conversion. Management of hypotension. Systolic BP goal greater than 100. Vasopressor agents to maintain systolic BP within prescribed range. Sustained hypotensive episodes are associated with a poor outcome. If the patient is having systolic BP greater than 185 mmHg or diastolic BP greater than 110 mmHg is not able to receive TPA, that is tissue plasminogen activator. Post-TPA, that is to maintain systolic BP less than 180 mmHg or diastolic BP less than 105 mmHg for first 24 hours post TPA, that is tissue plasminogen activator. The treatment include thrombolytic therapy, TPA, tissue plasminogen activator. TPA is given for ischemic stroke, not for hemorrhagic stroke. It dissolves the clot within the blood vessels by activating the protein that causes fibrinolysis. It must be given within 3 hours from the onset of stroke symptoms. It can be given 3 to 4.5 hours after onset if strict criteria is met. Recombinant tissue plasminogen activator is administered IV, is approved medical treatment for acute ischemic stroke. 0.9 mg per kg IV within 3 hours of onset of symptoms is given. Transarterial TPA within 6 hours of onset of symptoms. Benefits have been demonstrated in acute ischemic stroke related to occlusion of middle cerebral artery. Advantages include the following: higher concentration delivered to clot, can be performed in conjunction with mechanical disruption of clot, provides precise imaging of pathology and evaluation of collateral circulation, define extent of injury and recanalization. The disadvantages include the following: risk of hemorrhage related to catheter manipulation, dislodgement of clot, delay in thrombolytic therapy due to access delays, limited facility-based accessibility. To receive TPA, the patient should have a CT scan of head that is negative for hemorrhage, labs within normal limits, glucose, INR, that is international normalized ratio, platelets, all these things to be in normal limit. BP needs to be controlled. Systolic blood pressure should be less than 185 and diastolic BP will be less than 110. BP medication should be given if needed for hypertension. Glucose should be controlled due to increased rise of hemorrhage. Patient should not receive heparin or other type of anticoagulants. Monitor for bleeding. Neurological checkup should be done. Vital signs, labs, glucose should be monitored. We have to prevent injury by giving bed rest to the patient. Avoid unnecessary venipunctures. Avoid IM injections. Now we will see the inclusion and exclusion criteria for TPA therapy. Inclusion: onset of symptoms. The recombinant or IV TPA is given within 3 hours of onset of symptoms. The IA TPA or transarterial TPA is given within 6 hours of onset of symptoms. The National Institutes of Health Stroke Scale or NIS Stroke Scale is a tool used to measure the quantity of impairment caused by a stroke. No hemorrhage should be noted on CT scan of brain. Clearly defined time of onset of symptoms. Exclusion criteria are: head CT scan demonstrates early signs of infarction or hemorrhage. If the patient is having early signs of infarction or hemorrhage, we cannot give this TPA. If the patient is having uncontrolled hypertensive, that is non-responsive to IV or oral agent, we are not supposed to give TPA to the patient. If the patient is having glucose level more than 400 mg per dl, if the patient is on coagulopathy, heparin within past 48 hours, and if the patient is on warfarin, elevated PTT or prothrombin time, platelet count less than 100,000, history of previous intracranial hemorrhage, head trauma or stroke within past 3 months. If the patient is having GI or genitourinary tract hemorrhage in the past 3 weeks, history of major surgery in the past 2 weeks, in such patients we cannot administer TPA. Additional treatment options include transarterial or endovascular treatment, abscessimab, antiplatelet agent delivered intraarterially, verapamil, potent vasodilator, injected into intracranial vessel to treat acute spasm, clot retrieval or manipulation of clot, angioplasty and stenting have been utilized in acute dissection. Maintain normal glucose levels because hypoglycemia and hyperglycemia are associated with a poor outcome. Sliding scale insulin or insulin drip should be given to maintain normoglycemia. Maintain normothermia because hyperthermia is associated with a poor neurologic outcome. Deep vein thrombosis, that is DVT prophylaxis to be given. Sequential stockings and low dose heparin or low molecular weight heparin should be utilized. Focus on early rehabilitation. Next is acute treatment for hemorrhagic stroke. Support of vital functions, maintain airway breathing, oxygenation, circulation. Maintain pulse oximetry greater than 92%. Utilize oxygen therapy as needed. Arrhythmias are common in this also. Telemetry may be indicated to monitor. IV fluids at maintenance until able to tolerate oral diet. We should do neurologic assessment. Notify the healthcare provider of clinical deterioration. Deterioration can be related to rebleed or development of cerebral edema. Reversal of coagulopathies. Obtain patient's medical history. Medications to be concerned about include warfarin, aspirin, clopidogrel, ticlopidine, and dipyridamole or aspirin. Obtain INR, antiplatelet function analyzer, as ordered. Elevated INR is associated with warfarin use. PFA, epinephrine greater than 165 denotes platelet dysfunction related to aspirin use, and PFA adenosine diphosphate greater than 116 denotes non-aspirin platelet dysfunction, and has been used to determine the effectiveness of clopidogrel or ticlopidine or the presence of von Willebrand disease. Von Willebrand disease is a lifelong bleeding disorder in which your blood doesn't clot properly. As ordered, treat with platelets, cryoprecipitate or vitamin K to reverse coagulopathy. Prothrombin complex concentrate may be used for rapid reversal. Management of BP within prescribed parameters. Maintain systolic BP less than 160 to reduce vessel wall stresses. Goal is to prevent rebleeding while promoting adequate cerebral perfusion. Labetalol, hydralazine, nicardipine, or alternative IV antihypertensive agents may be used. Neurosurgical consultation for possible evacuation of intracerebral hemorrhage may be explored. Anticonvulsants to treat or prevent seizures after the patient's condition has stabilized. Treatment of clinical seizures with phenytoin or levetiracetam. Seizures commonly occur within the first 24 hours of intracerebral hemorrhage. Benzodiazepines such as lorazepam and diazepam also is given to treat seizures. We have to maintain normal glucose level because hypoglycemia is associated with a poor outcome. Sliding scale insulin or insulin drip should be given to maintain normoglycemia. Maintain normothermia because hypothermia is associated with a poor neurologic outcome. DVT prophylaxis, sequential stockings and low-dose heparin should be utilized. Data do not suggest any increased risk of hemorrhage in this population. Focus on early rehabilitation. Subsequent treatment include aspirin. Aspirin is the only antiplatelet agent that has been evaluated in acute ischemic stroke. Aspirin is recommended within 24 hours post-stroke. In TPA patients, aspirin should not be given until 24 hours post-TPA. Alternative antiplatelet agents include ticlopidine, dipyridamole or aspirin, and clopidogrel. Antispasmodic agents can be used for spastic paralysis. Early initiation of a rehabilitation program including physical therapy, occupational therapy, speech therapy, and counseling as needed. Depression is common for this patient. Therefore, early initiation of antidepressants can be beneficial, such as selective serotonin reuptake inhibitors. Corticosteroids such as dexamethasone to minimize cerebral edema, analgesics to relieve headache following a hemorrhagic stroke. Stool softeners such as bisacodyl to prevent straining, which increases ICP. Complications. The patient may have aspiration pneumonia, dysphagia in 25 to 50% of patients after stroke, spasticity, contractures, DVT, that is deep vein thrombosis, pulmonary embolism, brainstem herniation, post-stroke depression. Now we will see the nursing interventions for stroke. Maintain a patent airway and oxygenation. If the patient is wearing constricting clothes, we have to loosen it. Watch the patient's cheeks. If one side balloons with respiration, that's the side the stroke affected. If the patient is unconscious, the patient may aspirate saliva. Keep him in a lateral position to promote drainage or suction as needed. Insert an artificial airway and start mechanical ventilation or supplemental oxygen if needed. Keep the head of bed elevated 15 to 30 degrees to prevent increased intracranial pressure. Turn every 2 hours with proper alignment and watch for increased intracranial pressure during acute stage. Minimize activity of the patient. Maintain proper body alignment. Keep side rails in upright position. Check the patient's vital signs and neurological status. Record observation and report any significant changes such as changes in pupil dilation, signs of increased ICP and neck rigidity or flacidity. Monitor blood pressure, level of consciousness, motor function, voluntary and involuntary movements, senses, speech, skin color and temperature. A subsequent stroke may be imminent if blood pressure rises suddenly, the pulse is rapid and bounding, and the patient complains of a sudden headache. Watch for signs and symptoms of pulmonary emboli such as chest pain, shortness of breath, dusky color, tachycardia, fever and changes sensorium. If the patient is unresponsive, monitor his arterial blood gas levels often and alert the practitioner about increased partial pressure of carbon dioxide or decreased partial pressure of arterial oxygen. Maintain fluid and electrolyte balance. If the patient can drink fluids, offer them as often as fluid limitation permits. Give IV fluids as ordered and never give a large volume rapidly as this can increase ICP. Offer the bedpan or help the patient to the bathroom every 2 hours. If incontinent, the patient may need an interlinked urinary catheter. However, this increases the risk of infection. Ensure adequate nutrition. Patient is at risk for aspiration due to difficulty swallowing. Elevate the head of the bed 30 degrees with suction at bedside. Check for gag reflex before offering small amounts of semi-solid foods. Place the food tray within the patient's visual field. If the patient can't eat, insert an NG tube. Manage GI problems. Be alert for signs of straining as this increases ICP. Modify the patient's diet and administer a stool softener as ordered. If the patient is nauseous, position him on his side to prevent aspiration of vomit. Provide antacids to reduce the risk of ulcer formation. Clean and irrigate the patient's mouth or dentures to remove food particles. Watch for neglect syndrome. Tends to happen in right side brain damage. The patient at risk for injury because patient ignores the affected side. Remind the patient to use and touch both sides of the body daily. Must make a conscious effort to do so. Educate the patient about the importance of turning head side to side to prevent injury in the affected side. Hemianopsia intervention. Turning head side to side to see all visual fields to prevent injury. Interventions for aphasia. Just because the patient can't speak doesn't mean they have a mental deficit. They just can't get it out. It may take time. Our role is to help bridge the gap and make it less frustrating for the patient. Receptive aphasia. The patient is unable to comprehend speech. It affects Wernicke's area. Use short phrases, use gestures or point while giving a command. Be patient and not expect a fast response from the patient. Remove distractions. Expressive aphasia. Patient can understand the speech but cannot respond back with the speech. Be patient and let them speak. Be direct and simple when asking questions. Give options to the patient. Communication via a dry erase board. Stroke care is a multidisciplinary approach, need to involve family as much as possible because they will be providing care when patient is discharged. In addition, it is important to be always be communicating with the speech language pathologist, physical therapy, occupational therapy, etc.